I've gotten a request for that. So we're going to talk with a bit of a focus on two themes that you'll see when we get into the social determinants here. There's a ton of data now being generated and turning that data into intelligence. And then the second bit of a theme we're going to hit is this question around indices and a socioeconomic index. And what are the risks and pitfalls associated with that that we should take into account? So I want to confirm, you can see my screen here, the opening slide, social determinants of health, taking action on what matters. And after I give a brief overview of Jvion, I'm going to address our approach to social determinants of health. And we're going to peel back the layer of the onion, 3 layers. And so you'll get it, we'll see where that goes in just in quick 15 minutes, because I want to save 15 minutes for interaction, for questions and answers, dialogue if possible. So this is going to move very quickly without feeling rushed, hopefully. Just a bit about Jvion. We are in a market leading position. We've received industry recognition and also have a strong customer base in both the payer and provider sides that demonstrates successful outcomes that leverages the power of combined socioeconomic and clinical data. So when you put that together, then there's a theory or a belief that sometimes that can bring benefit, and math modeling is a projection of hope. We have the outcomes that demonstrate success in those arenas. And so we're very mature in this market compared to somebody who's done a data math model and says, well, the model performance is good. What we do is we provide, in that, if you see the 3 bubbles here, risk stratification, which is what any predictive analytics model will do. But beyond that, with the power of machine learning and large amounts of data that we have in our data universe, we will identify the patients that are modifiable. So not only those who are at risk, but those who are at risk that you can do something about, and then provide interventions that are specific to the individual patients that are based upon the drivers of risk. And you put all that together, and this is more of an intelligent approach, and it's the flavor of precision medicine, which is where healthcare is going. What we provide is the result of years of work, is as I described with our customer base. But what we do behind the scenes is a bunch of models and thousands of clusters, hundreds of thousands of clusters of patients that have similarity features related to them, so that when we get a new patient that comes in to the data set, to the data universe, that patient will look like patients in other clusters that are already built. And as a result of that, we know and can infer thousands of data points about them. So we know patients holistically, the socioeconomic data, the clinical data, we capture or we infer, and we can identify as a result patients not only where they are today, but who's on a path or trajectory for a high risk event. And we build our use cases around those events and those endpoints that everybody's trying to prevent, and it's associated with harm in healthcare. We take in a tremendous amount of data, socioeconomic data. We purchase and get and use those sources that we have at our disposal. We get clinical data from our clinicians, from our healthcare customers, and combining that together in the total solution. But that's a quick thumbnail on Jvion. Now, in the next 10 minutes, I'm going to cover what we do with social determinants in 3 layers. So the first layer is with publicly available data. We will, and we've done that. I'm going to walk through a brief analysis we did for the state of Oklahoma to illustrate with just publicly available data, we can risk stratify populations, whether at the county level or down even more narrow than the zip code level, down to the neighborhood level, populations and communities that are at risk. And this is helpful because as you're trying to understand risk in the communities that you serve, the socioeconomic drivers are there. But if you have zip code level data, it's too gross of a level of an average of the individuals within the community or even neighborhoods within the community for it to be as precise as you'd like it to be. There's a lot of money being spent, and some of it's being spent blindly as a result. So what we did here with Oklahoma is, and we can do this at the county level, we can do it at the zip code level, we can do it at the neighborhood level, but we create risk stratification only with socioeconomic data, scores 1 through 6. And we correlated that, demonstrating a very strong correlation between the social vulnerability risk score that we generated and the average cost per member per month. This was in the state of Oklahoma again, and that correlation was nearly fully explained by the socioeconomic risks that we were identifying. When we look at then differences by category, category 1, go all the way across, the weighted PMPM was $308 per month versus the highest risk category. So about 33% higher, $403, $404 per month in the highest risk category. So this shows some diversity and spread among the counties. I'm going to move to the next slide. The point I want you to take away from this slide is the heterogeneity of any population. So here's a sample of counties. And if we look at, and this is looking at high-risk population, high-risk patients within each county, but within those populations, they're not all at risk for the same reason. You take Beckham County in the middle here, and what stands out is their access to food is the biggest factor associated with risk, and second with education, and then unemployment. Whereas another county, take Atoka County, and the risk factors are income, housing, and transportation costs are entirely different. And again, this is at the county level. We can take this down to much more granular with only socioeconomic data. So if you're wondering, well, how do I get started? How do I understand my communities? This is a great way to get started. I'm going to touch on just one more detail here with food security. That we demonstrate, and there's a lot to take away from a slide like this. What we demonstrate and what we can tell is where a food bank is actually going to make a difference in the healthcare costs within a county or within a community. So there's a lot more here to cover, but for the sake of brevity and time, that's the bottom line, is that we are able to discern where a food bank is going to be most impactful. One other illustration of what this means and the context here is preterm birth and risks around that. And if I look at the highest risk counties versus the lowest risk counties, I can see some patterns emerge, but also again, some uniqueness by county. So if I look at the highest risk counties, what surfaces on average would be housing and education, and then transportation costs. Now, access to food doesn't look really remarkable, but for this one county in particular, Push-Mataha County, the access to food was very much the highest risk factor of every risk factor across the board in this matrix. In the same way, and you look at the lowest risk counties, preterm birth rates are very good there. And again, you can see the heterogeneity of the drivers of risk are different. So the takeaways here are, if you understand the drivers of risk for a population, whether it's a county or smaller block level segmented populations, then you can do something that's more targeted. Peeling the next layer of the onion back, if we get registry data, now we have some patient identifying data, and what we can provide here, if we have registry data and we combine it with socioeconomic data, that allows us to understand individual risk at the patient level. And that looks like this. When we start from a bottom-up standpoint, and we understand individuals, and then we roll them up to a population and then to a community, you might on the surface have the same net result or understanding of a community. Hey, their average risk in this community is driven by food, being in a food desert or lack of transportation. But when we start at the individual level, we understand which patients within that community are the ones particularly at risk that roll up to create that average, rather than assuming everybody inherits that characteristic that the community has. So what we provide at the individual level, and again, this is just with registry level data, very thin data set, is unique socioeconomic risks for each patient. So this is an example we'll provide, and along with identifying information, of course, we'll identify the ranking of their risk. And you can see you could qualify it in terms of moderate and other ways you can visualize it. And then the most important thing are, what are the drivers of risk for that individual patient? That allows you to be very specific when you pick up the phone, case manager calls that patient or that member for whatever reason and begins to ask more pointed questions. You get a better quality conversation, and the interventions can be more specific and valuable to that individual. Now I want to talk about indexes for a moment here. And if you put housing stability on a single scale and you called it an index for housing stability, we're missing that some of the features and drivers of risk are very different when somebody's been in a residence for a short period of time versus a long period of time. I'm going to draw your attention to the bottom here. This interactions, and this is from our AI machine learning standpoint, the interactions and drivers for a person who's been in short-term residence are tied to income, the renter status, and social support, among other things, but these are illustrative here of the drivers of other interactions in someone who's been in their residence a short period of time. Somebody who's been in a house a long period of time, the factors include income, marital status, environmental health hazards, because if I've been in the same house for 30 years and I'm drinking bad water, that's going to matter more than if I'm in a short-term residence, for example, and then job availability. So these are not two ends of a continuum on the same scale. And that is the fallacy with indexes, is that you put two conditions that appear on the surface to be on the same scale. One end is short-term residence, the other end is long-term residence. But the drivers of risk are very different between the two than they're really their own unique features. And a short-term residence situation could be good or bad, and long-term residence could be good or bad. And being on either end of that scale doesn't tell you if it's good or if it's bad, unless you understand the other factors that are driving that risk, which is what we come down to with the interactions here. Well, I hope that makes sense, and please feel free to ask more questions about that. I'm very interested in getting questions, and we're almost through the slides here, and invite anybody to comment on thoughts, questions, your experience. But the last layer that we provide is our Jvion core solution with the socioeconomic data combined with claims data. And when we get to that level, we can provide very specific very specific use cases for your population where a patient is identified as at risk, and the reasons are for both clinical and socioeconomic reasons. So this is the deepest layer of sophistication using socioeconomic data. And we provide those insights. What are the interventions that can be done to change risk for that individual patient? And this is just an example. This is related to medication adherence. And this is a patient that had some socioeconomic factors that were driving their risk around med adherence and things that could be done about it. And it includes, this is without going through the details of the use case, this illustrates how that information, that data, is converted into knowledge. So on that note, I will conclude I finished 2 minutes over. What I would welcome are any questions from the group, comments, and think about where you are on the journey. Are you leveraging socioeconomic data in any way? And if you're leveraging that data and you're perhaps investing in your community to impact your community, how effective is it? And I've got a question here. Go through the housing example, so I'll be happy to do that. So I'm going to make this point I'm going to just repeat it, and I'll dig a little deeper here on this point. When we think of an index, it's two ends of a spectrum. On one end is bad and the other end is good. And the implication is that we understand that the end of the spectrum is bad. If it meets this criteria, the other end of the spectrum is good. That's an index, high and low, good and bad. And the assumption in this case around housing stability is that housing instability is reflected by a short-term residence, which equals bad. And that housing stability is reflected by a long-term residence, which equals good. That's not necessarily true. So if we take action based upon the assumption that short-term residence is housing instability, which is bad, and we do interventions based on that, I'm going to give you a counter example for that. I'll take one patient, one member if it's a payer scenario. And this is an elderly lady who lives a long time in the same house. And so long-term residence is good. And she just lost her husband. And most of the other people have moved out. The house is decaying, costs are going up. And she's actually at some significant risk because she's in her long-term residence without social support. In this case, long-term residence is bad. But then she moves just recently to live close to her kids and her grandkids, and she has robust social support. She has transportation to doctor's visits, and better food preparation, more happiness in her life. And in this case, then, short-term residence is good. And so the fact that she is in a short-term residence or a long-term residence is almost irrelevant. It is the interactions with the other factors all converging to result in either risk or protective nature of her circumstances. It takes understanding all those interactions and how they work together to interpret it as risk. Otherwise, we're misinterpreting data as risk. And that's what indexes can do. So I hope that that helped. I didn't see you ask the question, but I hope that that helped to clarify the housing example and the risk around indexes. I have another question here. Good, I love questions. So how do we build our models? They're built around specific use cases. So there's two parts to that. We have the core data science, and I mentioned clusters of patients, and we have millions of patients, over 35 million patients in our data universe. And they math arrange into similarity clusters so that we have a starting point where we know a lot about those individuals. Again, over 4,500 individual features about every one of those patients, and they're both clinical and socioeconomic. From that point then we build, it's more than a model, it's a set of models for any specific use case. But at the end of the story, our products are a series of models that are built around a given use case, and that's the answer to your question. But it's a series of models because there are dozens of ways why a patient with diabetes might end up in the hospital. There are dozens of reasons why a patient who has a combination of socioeconomic factors and housing instability might end up not making it to their doctor's visit, et cetera. And so there isn't one path, and so there isn't one model. And I hope that that makes sense. I have another question. Can we purchase these different data sources and build prediction models by combining them with clinical information? It's possible. That's what Jvion has done. But that's the fly in the ointment, is that a lot of organizations and companies are trying to purchase data sources and then understand what the relative benefit is of this data source versus that, and how those combine. And you can end up with a prediction model that works well on your population, but doesn't work on any other population. The prediction model will also tell you who's at risk, but it won't tell you what can be done about it. And so prediction models are going to go away, and they're going to be replaced by, rather than predictive analytics, which is a predictive model, which is risk stratification, predictive modeling will be replaced with prescriptive analytics, which says not only do we understand the risk, but we understand why they're at risk. And we understand which interventions will change the risk for this patient sitting in front of me right here, right now. And so prescriptive analytics is where healthcare is headed, and predictive models are insufficient to deliver on what clinicians need today. All right. I'm getting the questions. I love the questions in chat. I much prefer dialogue. So I'm always wondering, did I answer your question? And I hope the answer is yes. I have one other question here. that the residence length does not follow a single continuum, and other socioeconomic risk factors behave similarly, where low and high aren't on the same continuum, or good or bad, depending on the patient and their interactions. And I can't speak to every one of them, but a majority of these could be in the same a category where they don't necessarily follow good and bad on a continuum. I think we could say food insecurity and living in a food desert is probably on a single continuum. Access to food is good. But I'll give you another one where it's very counterintuitive. Let's take high income. And there are individuals, again, if you think on a scale, high income good, low income bad. But there are individuals where high income combining with other features is elevating their high income as a risk because of at-risk behaviors. And it could be related to their propensity to eat out every night, have a very rich diet, and be overweight. It could be related to high-risk behaviors like substance abuse, and some of the affluent population types of substance abuse are higher, or reckless living, and the means to do so. And so not everybody who is in the lower income status is at risk, and not everybody who's in the higher income higher income status is protected. It is a combination of other factors, as we say here, the interactions. These interactions with other drivers of risk are the most important thing. So it isn't any one feature that equals risk. And again, that is a huge misperception in healthcare today, is if I know this feature, it translates to risk, and it just isn't true. I've got another question. How does our software identify which interventions work for the patient? And this is really machine learning. So when we have to have the outcomes. And again, when we have over 35 million patients in our data universe, those are patients from our customer base with clinical outcomes tied to those, and interventions in many cases of those millions tied as well. So the machine learning component, this is artificial intelligence, indicates these interventions were more effective in this scenario for this patient that is in this similarity cluster, where, again, I'll use the example where this diabetic who lives alone and has limited social support, transportation was a really big issue. That risk factor, if we adjust transportation, is more likely to get them to the doctor's office. Now, this diabetic over here who looks the same, but also has indicators and features indicating depression, social support, and getting into a weight management group might be the most impactful thing for that individual, because it's actually components of depression that are pressing more on that individual's risk with diabetes than this patient with diabetes over here that had predominantly transportation issues. So it's machine learning that indicates those interactions of features leading to an outcome, and that outcome is a patient in the middle of a cluster that's a risk cluster. And good, I love the questions. They're coming just at the pace of me answering them. So speak a little more toward how Jvion determines the drivers for the area or the patient in question. This is getting into the deeper data science that in the time remaining, even if I had another hour, probably couldn't do it justice. So I won't blame the lack of time on that one. At a high level, again, it takes large amounts of data, and it does take sophisticated machine learning to interpret which features around these patients are contributing to an outcome. And once I know that for a group of patients, that these are the features wrapped and interactions of those features wrapped around this cohort, say 100 or 1,000 patients leading to this outcome here. If I have the next patient that looks like that group of patients, and it looks like it from a math standpoint, these features in common, and all those features are drivers of risk. The drivers of risk equate to the outcome occurring if we're correct in understanding those risk drivers. Hopefully that makes sense. But if the machine learning is accurate in its interpretation, then the outcome is predictable. We've demonstrated competency in that space. So to the earlier question, can we just buy the data and do this? And the answer is, for the most part, big tech companies have tried it. Single organizations have tried it. There are many challenges, and the challenges usually translates to overly committed expectations and under delivering on the results. I love the questions, and I do have time for one more. It's 12:28 by my clock here. I'm going to advance the slides to see if there's anything we didn't cover. We'd be happy to continue a conversation with you. Appreciate your time today. And again, think about this as a closing question for you all. Are you leveraging socioeconomic data today in a way that's turning it into intelligence? And if your initial answer is yes, and many times I've had that initial answer be yes, dig a little deeper and ask yourself, for the organization, what are we really getting for it? And be data-driven in your answer. In other words, how many people's lives have we impacted? Are we making a difference? Or have we just thrown a bunch of money and resources at it and we believe we're making a difference? I'll leave you with that question, and thank you very much for your time today. I'll turn it back over to Jay.
Great. Well, thank you all for coming. We have a recording of this webinar that we'll be publishing probably over the next week and make accessible to you. And you know, if you have any other questions, please feel free to reach out to us. We'd love to talk to you.
Thank you so much.